Hello, I'm Dr. Israel Barken, the Medical Director of the Prostate Cancer Research and Education Foundation, and today we are going to talk about a favorite subject. What do we do with patients that have high-risk prostate cancer? The first article we'll discuss will be identifying the best candidate for radical prostatectomy among patients with high-risk prostate cancer. This was published in the European Urological Magazine 2012 in March. So let's go now and discuss the article. Identifying the best candidate for radical prostatectomy among patients with high-risk prostate cancer. This is an article by an author by the name Briganti. You could tell he's Italian, Department of Urology, Vita Salute University, San Raffaele in Milan, Italy. Let's go now and look at the abstract. The background. The current role of radical prostatectomy in patients with high-risk disease remains controversial. I brought you last week the article from Johns Hopkins, 1990. It was controversial then, it's still controversial today. The objective of this paper was to identify which high-risk prostate cancer patients might have favorable pathologic outcome when surgically treated. So let's look now at the design, setting, and participants. They evaluated here 366 patients with high-risk prostate cancer, at least one of the following risk factors: PSA more than 20, CT3 means clinical T3, it means it's still confined to the prostate, not outside of the prostate, but abutting with a capsule. Biopsy Gleason 8 to 10, treated with RP with pelvic lymph node dissection. This is a very important point because some people believe that in the high-risk patient you should perform an extended lymphadenectomy and not a limited one. This is a very large experience from 8 European centers between 1987 and 2009. A favorable pathologic outcome was defined as specimen confined. They term it as specimen confined SC disease, namely PT2 to PT3A. PT2 is on both sides of the prostate, inside the prostate. PT3A is already going through the capsule on one side, and it's not negative PCA with negative surgical margins. The results. There were overall 505 of the 1,366 patients that had disease localized to the prostate at RP. This is 37%. All preoperative variables, age, PSA at surgery, clinical stage, and biopsy Gleason sum, were independent predictors of finding if really it will be only localized to the prostate. Patient with specimen confined disease had significantly higher 10-year biochemical recurrence-free survival and cancer-specific survival rates than patients without specimen confined disease at RP. The percentage here, you see the difference, 66% versus 47%. This was in relation to the BCR, and 98% versus 88% respectively. A nomogram, including PSA, age, clinical stage, and biopsy Gleason, showed 72% accuracy in predicting whether the specimen was confined to the prostate. This study is limited by its retrospective design and by the lack of external validation of the nomogram. So let's go and look now at the conclusion of the article. Conclusion. Roughly 40% of patients with high risk, they have specimen confined disease, and this is important because these patients are excluded usually from having radical prostatectomy But when you find out that roughly about 40% of them may have localized disease or specimen confined in final pathology, it shows that these patients showed excellent long-term outcomes when surgically treated, thus representing the ideal candidate for RP as a primary treatment for PCA. When I say primary treatment, you have to remember that many of the patients that are high risk and do not have radical prostatectomy, they are exposed to hormonal blockade, which also affects their quality of life or perhaps even survival because of the cardiovascular problem. Prediction of such patient is possible using nomogram based on routinely available clinical parameters. I would say that we could tease out or define or refine better the stage of the patient by using imaging techniques like the multiparametric spectroscopic MRI. So you see, this article is in favor of radical prostatectomy, and the point is that if you start with radical prostatectomy on high-risk patients, you may have a large portion of patients that you could avoid over-treating them with hormonal blockade just because without the radical prostatectomy, you will not have the information of the staging and exactly even the downgrading of the cancer that will be shown only after radical prostatectomy. So in this case, radical prostatectomy is not only a treatment, but it's a very good diagnostic, prognostic test to help the doctor and the patient to make a decision whether they want to give systemic treatment additionally after the radical prostatectomy. And here they have a choice. If the disease was only localized to the prostate, then there is no need to put the patient on hormonal blockade, and follow-up showed that these patients actually are doing very well. Thank you for listening. If you have any questions, please write to us at info@pcrev.org or call us at 906-4700 in area code 619. I repeat the number, 619-906-4700. Stay well, stay informed, and have fun. Goodbye.